Hello, everyone. I'm Demetrius Peterson, attorney in Husch Blackwell's Higher Education Group. Before we begin, I would like to cover a few housekeeping items. At the bottom of your audience console, there are multiple application icons for your use during the program today. If you have any questions during the webcast, please submit via the question box. We will try to answer all questions during the webcast today, but if a fuller answer is needed or we run out of time, it will be answered later via email. A PDF of the presentation is available in the resources folder. The program has been approved for continuing legal education hours. To report your hours, click on the CEU icon at the bottom of the screen. A certificate of attendance, including course numbers, will be emailed to you tomorrow along with a recording of the webcast for watching and sharing. Toward the end of the program, be sure to complete our short survey. We use our feedback to plan future programs that are applicable to your business needs. That is all of the housekeeping items. Let's get started with our program today. Joining me today are Jason Montgomery and Dr. James Borchers. A former NCAA investigator, Jason represents colleges, universities, and student athletes nationwide in enforcement, eligibility, and compliance matters. Colleges and universities at all levels seek out Jason's unique ability to navigate NCAA rules and resolve complex issues related to NCAA infractions and eligibility matters. Dr. James Borchers is the co-founder of the U.S. Council for Athletes' Health. He is a leading expert in student-athlete healthcare and has over 15 years' experience in both leading and consulting with organizations regarding all aspects of student-athlete healthcare and safety. And without further ado, I want to pass things off to Dr. Borchers to get started with our program today.
Demetrius, thank you very much, and good afternoon to everyone. And thank you for joining us here today for this Athletics in the Era of COVID-19 Return to Sport Winter Edition. COVID-19 has certainly affected many of the things that are going on around the world today, but certainly in the area of athletics and especially collegiate athletics, COVID-19 has had a huge impact, maybe highlighted by a record number of NCAA Division I football games that are being postponed or canceled this upcoming weekend. So by way of introduction, as Jason mentioned, we're going to discuss athletics in the era of COVID-19 today, really breaking it down into 8 categories. The first category is some general information about COVID and some updated information and things that we should be expecting. The second category is the actual impact and risk on health, and specifically as it pertains to collegiate athletes. We'll then shift to policies and protocols for safe athletic participation. We'll address COVID-19 testing. We'll talk about the isolation and quarantine for athletes, determining when athletics start and stop with COVID-19. We'll talk about the ethics of athletics in a pandemic, and then finish with our last category, which is the NCAA actions and guidance that are around athletics at this point in time. I think as we address the first category here, general information about COVID-19, I think we're all familiar with what COVID-19 is, but just by way of reminder, COVID-19 is a disease process that has been attributed to the SARS-CoV-2 virus, a coronavirus, a family of viruses that cause a number of common upper respiratory infections. But this specific coronavirus is more virulent and finds its home in the lower respiratory system of human beings. As we know, COVID-19, one of the things that makes it so difficult is that it's spread by respiratory droplets, and so it's spread very easily from individuals that have it to those individuals that do not, and makes it very difficult to contain this virus without mitigating factors. We know that there are strategies that are proven to limit COVID-19. Those strategies include mask wearing, physical distancing of 6 to 10 feet from individuals that you're not familiar with, avoiding large gatherings, and using good hygiene. Those strategies, when followed appropriately, have been shown to significantly decrease the spread of COVID-19 and certainly have been instituted in athletics. We've gotten a lot of questions about when a vaccine will be available. You probably are all aware this week that both Pfizer and Moderna have announced some preliminary findings on vaccinations and some very encouraging findings on their effectiveness. States are preparing now to receive vaccine in the month of December to begin vaccinating high-risk populations, beginning with healthcare workers and then those individuals that are at highest risk if they were to contract COVID-19. And we believe that beginning in late March, early April, we should start to see the distribution of vaccines to the general population, meaning that in the months of April, May, and June, we're very hopeful that those that choose to receive the vaccination will be able to do so, including collegiate athletes, staffs, coaches, and others that would be preparing to participate in a 2021 season. The other question that comes up frequently that I think we need to address is the idea around treatments for COVID-19. And fortunately for us at this point, we have seen a significant difference in the way that we treat COVID-19 than we did in February and March when this pandemic first had its first spike in the United States. We certainly have found some antivirals such as remdesivir. There are now monoclonal antibody treatments that can be used in the sickest of patients. We're using treatments such as steroids or dexamethasone, which have improved the care of our sickest patients. And so we've become much more effective at treating and managing patients with COVID-19. Not to say that there aren't individuals that are still becoming significantly ill and requiring intensive care treatment and other significant healthcare resources to improve. But fortunately, those individuals are most frequently not in the age group that we're talking about, in the age group of 18 to 29 here today for this discussion around athletes and collegiate athletes. Unfortunately, there are no good outpatient treatments for COVID-19. We have no oral antivirals or other medications that have been shown to affect either the transmission of the disease process or the severity of the disease process in individuals. And so as we continue to monitor effectiveness in combating the pandemic, certainly the development of outpatient therapies will be very important. I think that, we need to consider what's happening right now, and this slide, just a bit dated, but certainly shows what has happened in athletics over the past 7-8 months. We know that back in April, we had seen that the first peak of COVID-19 at around 30,000 new cases per day in the United States, and that's when we began to plan for a return to sport. We started to see that to decline until we got to right around early July. And then just as we were thinking about coming back to sport in most collegiate settings, we started to see the number of cases increase and reach a nadir of about 66,000 new cases per day in the United States. Fortunately, we saw a decline then in the numbers of cases, and as we got into the early fall in September, and we started to notice that obviously those new cases were decreasing. But as you all know, very rapidly through the month of October and now into December, those cases have increased. And just yesterday, the number of new cases in the United States is at about 140,000 new cases a day. And so just to put that in perspective, we're at about 4 times where we were in April and 2 times of where we were in July. And so certainly I'm concerned about the rapid spread of the virus at this point. But we really shouldn't be surprised by this. This slide here discusses the estimated infection, and the Institute for Health Metrics and Evaluation has really been spot on with where they have been in predicting the spread of the SARS-CoV-2 virus and COVID-19. And the reason to put this up here is not to be an alarmist. It's just to say that we need to be prepared as we deal with athletics, and especially as we think about athletics moving indoors in the winter sports season and how we would potentially be able to proceed, that we expect in early December will be higher than we are now, and that without significant improvement in some of the mitigating factors that we talked about, that we should expect to see this infection continue to spread, and most likely continue to spread within young adults, which is where we've seen the largest spread over the last couple of months. So this gives us some background then to begin to think about athletics as we move into the winter sports season. It's important that we understand what the impact on health, risk on health is from COVID-19, and especially in the age group that we're talking about, the immediate health issues, the potential long-term health issues, and then the complications that are really important to athletes. And we need to have some background here as we think about how we move forward with sport and understand it. This is a slide that just shows a simple graphic that discusses the difficulty with differentiating on subjective symptoms COVID-19 from common things such as colds and flu, because many of the symptoms and clinical markers that we use to identify COVID-19 have significant crossover with things like the cold and flu. And so it has been very difficult for us to identify a clinical syndrome that has really identified COVID-19, which has made the need for testing so important to be able to isolate individuals with this virus. In fact, it's been shown that probably 85% of individuals with common symptoms that we think are significant for COVID-19 actually don't have COVID-19 and have some other viral infection, most likely that are causing some of their upper respiratory or common viral symptoms. I think everyone's familiar with the loss of taste and smell, and certainly the loss of taste and smell has been used as a common marker for COVID-19 and is probably the best indication that we have for individuals that develop those, that they likely have been infected with SARS-CoV-2 or having effects from COVID-19. That being said, we do need to understand there is an impact and risk on health in all individuals, regardless of age, from COVID-19. And again, just to identify with this slide here, that we see those in many different systems throughout the human body, and that's very unique to the SARS-CoV-2 virus, that it tends to affect multiple body systems, including the respiratory system, the neurologic system, again, issues around loss of taste and smell, but certainly headaches, fogginess, difficulty with memory, those sorts of things. There is some extreme fatigue that can be noticed with SARS-CoV-2 and COVID, and then certainly heart-related issues, which we'll talk about in a minute. But again, just a number of symptoms that are certainly related to SARS-CoV-2, and one of the reasons, again, why it makes it difficult from a clinical standpoint to make a definitive diagnosis and why it requires some further testing. And also just to also mention here that there are individuals that are asymptomatic or so mildly symptomatic that they would not identify themselves as being ill and can still be affected by COVID-19 or SARS-CoV-2. One of the particular issues that we've been asked about and discussed in detail has been myocarditis and the associated risk with SARS-CoV-2. And this schematic here is not meant to have a dissertation on cardiology, but just to identify that the SARS-CoV-2 virus does have specific predilection for the ACE2 receptor, which is found mostly in heart or cardiac tissue and then lung tissue. And so it does have a larger predisposition for affecting the heart than some other common viruses that we're aware of. That can lead to inflammation of the covering of the heart or the pericardium, and can lead to swelling there and could precipitate arrhythmias or abnormal rhythms in the heart, which is certainly a concern with this virus. And it can also lead to microvascular ischemia, or a lack of blood flow from small vessels to the heart muscle, which again can lead to arrhythmias and weakening of the heart. Although in the acute phase, fortunately, we're not seeing significant symptoms or infection that is affecting the heart in most young athletes, one of the things that we're not aware of yet are the long-term effects, and very similar to drawing similarities to the risk of injury from concussion. We just don't have enough experience yet to be able to predict all the long-term effects that someone with COVID-19 may have, even if they're a young person and they had some effect on their heart. And so certainly from our cardiology colleagues, electrophysiologists and cardiomyopathy specialists, they worry about things that can affect either arrhythmias in young people or weakening of the heart, these non-ischemic scars, which can lead to fibrosis and scarring, which can cause abnormal rhythms and weakening of the heart. Again, it appears that this is a rarer occurrence to have the acute phase of myocarditis in athletes, but it's certainly thinking about the potential for chronic issues and having just a pause as we consider this and the return to athletics is important when we consider health risk. And this has led to a number of organizations, including experts in cardiology and sports medicine, putting out algorithms that help us to define how we should return folks that are positive from COVID-19 to play when we consider the cardiovascular risk. And these algorithms and schematics are available, and this slide is here just to remind us that as we think about return to sport or continuing with sport, we should have a consistent methodology as we're going to evaluate athletes and return them to sport when they are diagnosed as COVID-19 positive. The recent NCAA resocialization guidelines, which were just released again today in the second edition, make reference to some of these algorithms and certainly are things that medical staffs, athletic organizations, and certainly risk management folks want to be aware of as they think about how to evaluate athletes that are COVID positive that are going to be going back to sport. And so thinking about that risk will be important. Suffice it to say, probably the most important thing from a myocarditis risk factor is that anyone who's COVID positive should meet with their healthcare provider to make certain that they have had a discussion about not only their symptoms, but their return to sport progression, athletic progression, and any required testing that would be recommended by their healthcare provider prior to returning to sport. This next slide is here provided by the CDC, and this really has not changed much over time. But again, if we look at the comparison group we're interested in, which is 18 to 29-year-olds, if we think about collegiate athletics, fortunately, we know that hospitalizations in younger people is significantly lower, and certainly death is significantly lower. But again, the CDC has continued to come out with data that suggests that the most significant risk for COVID-19 from morbidity and mortality, which means requiring hospitalization and acute care, and death is over the age of 65. And so we can see that as we get into those, when we compare those age groups, fortunately for our collegiate athletes, and especially without comorbidities, there seems to be mostly mild disease that's caused by COVID-19. And so the risk has been suggested to be significantly lower as it is than older individuals. Probably the most important thing to note here is that when we do consider comorbidities such as obesity, hypertension, or asthma, just to name a few, even in this age group, we need to be just slightly more cautious and aware of the risk that could have on someone if they were to contract COVID-19 and could affect their return to activity or certainly their monitoring when they have the disease itself. But again, this schematic really supports that if you think about safe recovery statistics, most individuals in the 18 to 29-year-old age group, even at a rate of about 99.98%, will have what is considered to be safe recovery from COVID-19. And so certainly we know that most college athletes, even if affected by COVID-19, will recover from the disease in a safe fashion without needing acute care or hospitalization. So that leads us to our third category, which is really the policies and protocols for safe athletic participation. And there's certainly examples of those policies and protocols that are needed with COVID-19. Just like any other healthcare issue, we need to have policies and protocols in place that help our athletes deal with this. We get asked often, should they be available and transparent with athletes and stakeholders? And I think you're going to hear here in just a minute that transparent policies and protocols should be available to everyone as we think about this. And then thinking about education and compliance and what are best practices. So just by way of review, it is really important that sport-specific policies and procedures are identified as we think about the return from COVID-19. Each sport has different physical contact and distancing needs and requirements. And in fact, when we think about high, intermediate, and low risk transmission, It's important to note that we really have not seen evidence of much transmission, even in high-risk transmission outdoor sports for COVID-19. We anticipate that to change as sports move indoors as the winter months come closer here and we transition to more indoor sports. But we have not seen in the sports of football, field hockey, soccer, and other sports, even internationally, the risk of transmission during actual sport activity itself. But we should have policies and recommendations specific to each sport. We certainly should be developing sport and health hygiene policies for personal and group hygiene, and certainly this is around areas such as locker rooms, personal equipment, etc., to reduce any risk that would be associated with COVID-19. But probably most importantly is a change in culture and making certain that we have a culture that helps us to mitigate the risk that's associated with COVID-19 and ensuring that every stakeholder should be educated regarding COVID-19 and making certain that we follow through with that education in a standardized, traceable fashion, and that we do know that it's recommended that all athletes and every stakeholder involved in athletics should be monitored daily regarding symptoms and physical distancing. And so by ways of example, you can have different modules or education for COVID-19, certainly specific to athletes, coaches and support staff, administrators, and then academic staff and students, and then also important to educate on the post-COVID-19 risk and considerations that we know about to make certain that we're following the principles of autonomy and informed consent when athletes and others are thinking about their participation. And so doing this certainly through electronic learning modules is something that can be tracked and traced and is recommended by our group as one of the best practices to make certain that this education is offered to all stakeholders. And certainly, as we mentioned, using a survey or some sort of daily monitoring tool that incorporates, we believe, education along with symptoms to make certain that individuals daily are reminded of their responsibilities and certainly making certain that no one's participating in sport if they should be evaluated by a medical professional. And so at this point, I'm going to stop here and then turn it back over to Demetrius Peterson from Husch Blackwell, who's going to spend some time talking about some of the assumption of risk and other policies and protocol issues around COVID-19. Demetrius?
Thanks, Dr. Borchers. What I want to speak about right now is about assumption of risk forms. I know over the course of the summer, as schools geared up for fall sports, we received quite a few inquiries and gave some assistance in creating this assumption of risk forms. We anticipate that that's going to continue as winter sports resume and as schools transition into the spring sports season. And so I just wanted to go through a few things that you should consider when you are thinking of developing an assumption of risk form. First of all, when you're working on these forms, you may want to consider either consulting with your legal department or outside counsel when drafting one of these forms, because they are extremely there are state-specific rules that will apply. But the first thing that we're going to talk about now is just the education portion. When putting together an assumption of risk form, you want to make sure that you educate your students on the assumption of the risk. And you do that by providing express notice that they may contract COVID-19, even if the institution does its best to follow the CDC guidelines or other public health recommendations. You want to make sure that athletes are aware of the reporting protocols on the assumption of risk form. You want to make sure that the form calls out that there may be possible quarantine or isolation as a result of participating in the sport. You also want to call out specific procedures for entering facilities. Whether or not there's going to be a daily symptom checker, whether or not they're going to be required to do a temperature check before they enter the building. If there are specific entrances or exits, you can call out some of those things within the form to make sure that they have a full idea of what the institution is going to do and about the risk that may result. So now we have our first poll question. The first poll question is, my institution requires students to sign the assumption of risk form before returning to their sport. Okay, it looks like it's about half and half. It looks like 45% of the institutions right now are requiring an assumption of risk form, and 54% are not. So it looks like it's a pretty even split. And so if you are using an assumption of risk form, or maybe your institution is thinking about using an assumption of risk form, this slide just illustrates here that courts typically disfavor assumption of risk forms and waivers. And so if you're planning on using an assumption of risk form or a waiver, you want to, there are a few things you need to do. First of all, just like at the previous slide where we discussed the educational component, it's on here. Also explaining that the program is taking measures to help lessen the transmission, but as we discussed previously, it's impossible to prevent all transmission of COVID-19. You also want to highlight that another important step is to require that the student athlete acknowledge that this is voluntary and that it's not a mandatory decision that the athlete participates in the sport. You want to utilize conspicuous formatting, and what that means is we want to make sure that things that need to be highlighted, that we're doing so with document headers, by putting things in bold that are really important, by underlining things, by italicizing things. Those are things that a court will look at to see if you made these things conspicuous on the form. Requiring the athlete to sign the form and retain a copy is also important. And then just do the things that you say that you're going to do. I do want to call out, and Jason's going to talk about this a little bit later in our presentation today. The NCAA has provided specific guidance as it pertains to waivers, and so we'll discuss that later on. The next thing we want to talk about is how do we follow through on some of those steps that we just talked about. You want to identify mandatory obligations for reporting, for gathering. You want to make sure that you have a training program that informs student athletes where they're supposed to go if they're feeling ill, where they're supposed to go if there's been an exposure. Make sure that everything is spelled out. You also want to determine consequences. So if you say that something is mandatory or that people are required to report, or that a specific training is mandatory, you're going to want to make sure that there are consequences for those for not following through with those tasks. And so you're going to want to think through before you make something mandatory, or you're going to want to decide what those consequences may be, and if those consequences are going to be different for students, coaches, or staff. Another thing is, just as we discussed, I said the previous slide, you want to make sure and follow your plan. And how we follow our plan by training on it, making sure that everyone's informed, also by publishing all the education, whether it's in a department-specific hub that everyone, including student athletes, can access, or just making the forms available published on a website. But you want to make sure that all the steps that you are taking and the things that people are required to do are that they have access to those plans, so that they know where they're supposed to go and that they know the protocols. Another important step and kind of a pitfall in this is, if you're thinking of all the different options and all the different things that you should do, you want to make sure not to overcommit yourself on protocols before you've secured the ability to actually implement those protocols. The next slide here would apply to NCAA institutions. And so the NCAA did provide guidance, and it's available on their website to member schools about actionable plans. And it says that athletics personnel are encouraged to reach out to campus healthcare leaders at their respective schools to safeguard the well-being of student athletes, employees, and fans. And so what it says is that even as a separate, if you're operating separately as an athletic department, you still should, you're still have the responsibility for ensuring that your plans are in place. And the guidance on the NCAA site, they really talk about partnering with people on your campus, healthcare professionals and leaders when you're trying to develop these plans. Next, as far as reporting, once again, this is available on the NCAA website. The NCAA states that athletic department staff should notify the appropriate campus departments whenever anyone associated with the athletics department shows symptoms consistent with COVID-19. This is just a reminder that it's not just student athletes. This could be support staff. This is training staff. This is anyone that would have could come in contact with other individuals, whether it's a coach or a player. So that's just something to keep in mind. Another thing that I wanted to discuss briefly is the NCAA did establish a COVID-19 concern line. There's a phone number and an email address that allows student athletes, parents, and others to report potential return to sport concerns. That number is on the slide. But in this process, the NCAA will notify school and conference administrators who are expected then to review the concern and address the concern. And anyone with concerns regarding the NCAA return to sport guidelines are encouraged to report. So they don't necessarily have to be a student athlete. It can be a parent or someone associated with someone in the program. And so with that, I'm going to hand things back off to Dr. Borchers, who's going to speak next about COVID-19 testing.
Thanks, Demetrius. Appreciate that. So our fourth category today is to briefly talk about COVID-19 testing, which has seemed to get a lot of attention as we return to sport. And just to start with a general statement, to understand that testing reflects what goes on with behaviors, and so testing is really just a way to either monitor or to diagnose COVID-19. So we'll talk briefly about the types of tests that are available, their effectiveness, how often should athletes be tested, who should be tested, symptomatic and asymptomatic athletes. Does testing make athletics safe with COVID-19, and should we have athletics if testing is not available? And so when we think about the types of testing that are available, we know that there's two types of testing available. We have both the molecular test or PCR test, which you're familiar with, the most sensitive type of test for making a diagnosis of COVID-19. These tests are usually obtained either by a nasopharyngeal, nasal swab, sometimes an oral swab or saliva. They require a lab to have the testing done, and oftentimes require some time to get the results, and in some places even over 24 hours still to be able to get results from these specialized tests. And really before COVID-19, these tests were used mostly in very sick or hospitalized patients to make diagnosis of various infections. We also know that there's been the advent of more rapid test or antigen testing, which looks at viral proteins. These tests are normally done very quickly and effectively in a short amount of time. They are not as sensitive as PCR tests for making the diagnosis, but their sensitivity has improved. We get real-time results, usually within about 15 to 30 minutes of those tests, so we can identify individuals that are potentially infected with COVID-19 very quickly. We're going to talk here in a minute about how athletes should be tested, and there's been a lot of discussion around should we test symptomatic or asymptomatic athletes, and I think the concern there is around asymptomatic individuals being able to obviously confer transmission of the virus to other individuals, and so considering who needs to be tested and when they need to be tested. Certainly along with this becomes when should we begin to retest someone who's had COVID-19 in athletics, and as you may know, we'll talk briefly about CDC recommendations for retesting, but certainly brings up issues around athletics as well. And the question around athletics if testing is not available will be addressed in our seventh category around ethics, but suffice to say there's been a number of situations where athletics have been doing well without any testing and may speak to transmission, at least in outdoor sports with COVID-19. So just by way of looking at testing and its impact on infection reduction and contact tracing, If we look at the infection here, the gray line here shows the typical infection course of COVID-19. And as we look further here, this green bar here is the detection threshold of PCR. So very sensitive, as we mentioned, PCR at about 1,000 copies of the virus per milliliter can detect the infection. So really at a point before someone becomes symptomatic or infectious, and certainly, as you can see here, for a very long period of time after the person may actually have the infection. If we look at this next line, we look at the infectiousness threshold. So you have to have about 1 million copies of the virus per milliliter to be able to be infectious to someone else. So there is a lag period of time or a latency period where someone may actually be harboring the virus, but they're not infectious to someone else, and they may be asymptomatic. And so it's important to identify those people before they become infectious to someone else. And certainly that's important if we think about keeping groups of athletes safe if we're going to be using testing strategies. It's during this time period where we obviously in that infectiousness threshold understand that people are putting others at risk. And certainly in that time period before they become infectious, if we can identify them, we can remove them before they can cause further infection. And antigen testing is certainly not as sensitive. You need about 100,000 copies of the virus per milliliter to detect COVID-19 or SARS-CoV-2 from antigen testing. But it is still possible if we're doing antigen testing frequently that we can identify individuals and remove them very quickly from the population in strategies to be able to avoid people becoming infectious to other people. And certainly from a public health standpoint, this has been a strategy that's been discussed with at-home rapid testing and doing more frequent testing and the more complex PCR testing in order to allow individuals to identify themselves as potentially infected with the virus and to isolate. So if we think about testing strategies and looking at testing strategies for surveillance, which is really what we're talking about in athletics, we're not talking about making the diagnosis in these individuals. We're trying to do surveillance to make certain that we're identifying individuals that might potentially have the virus and removing them. This is a strategy that has been suggested off of modeling on a very well-cited paper looking at the type of test and turnaround time. And although PCR testing may be the best test for making the diagnosis and the most sensitive test for looking at the virus, it may not be the most cost-effective or best strategy for thinking about surveillance in our populations, and so certainly with athletes. And you can see here that regardless of the sensitivity of the test, if we look at turnaround time and the frequency of when we're testing, certainly the reduction in infectiousness in the population goes up the more frequently we're testing. But looking at antigen testing, even if it's a 1-hour turnaround time, and remember I said most of those are about 15 to 30 minutes, even if we get to antigen testing twice a week, it has about the same in a surveillance strategy, the same effectiveness theoretically as PCR testing, where we have a 24-hour turnaround time twice a week. And antigen testing every other day reduces infections to about 95%. And so many people have talked about strategies with antigen testing 3 times weekly. And certainly if we get to the point where we have antigen testing every day or PCR testing every day, we very quickly start to approach 100% reduction in infectiousness, because with the frequency of the evaluation, we are identifying individuals before they become infectious to someone else and removing them from the population and isolating them so they can't infect others. And so many of these strategies have really been the strategies that have been thought about when we think about testing as it applies to athletics. And it can be used to think about if we should employ a testing strategy for athletics, and what the effectiveness of that actual testing strategy is. And so, again, just looking at PCR testing just once a week in a surveillance strategy in an asymptomatic population, we really only reduce infectiousness to about 60%. So we need to think about that and the effects that it can have, especially on contact tracing. And so one of the advantages of surveillance testing is that if we're doing it frequently, we can identify individuals before they become infectious and can remove them from the population before they can infect anyone else. And therefore, at least within the activity itself, practice or competition, can make certain that no one on the field would be able to infect someone else if they're all following the same sort of testing strategy. So it brings us to this second question, and just to see as we think about testing and what the views of testing are. So COVID-19 testing is commonly performed using either antigen or PCR testing, as we just discussed. And coming to this next part, is PCR testing more sensitive than antigen testing for confirming the diagnosis of COVID-19 in an individual? And so if we look at this, we see that most of you, as we just discussed, would say that that's true. And I think it's important to know that if we're going to confirm the diagnosis of COVID-19, PCR testing is definitely the most sensitive test. But when we talk about surveillance testing, it may be that if we can test more frequently with antigen testing that has appropriate sensitivity and specificity, that we can be more effective in reducing infectiousness during activities such as sport. So the fifth category is one that has been discussed quite a bit, which is isolation and quarantine for athletes. Who's appropriate for isolation and quarantine? How long should that last? And can athletes in isolation or quarantine exercise? And as we think about the last part of this question as we go through this, it's important to understand that there are guidelines about exercise for those athletes that are COVID positive, but asymptomatic and in isolation, and certainly about those that may be in quarantine, and we'll discuss those here in a moment. So based off of CDC guidelines and recommendations, if you think or know you've had COVID-19 and you had symptoms, you can be with others. Again, it's after 10 days since symptoms first appeared, so that 10-day period of isolation. But also along with that, you must have at least 24 hours with no fever, without using any sort of fever-reducing medication, such as acetaminophen or ibuprofen. And the other symptoms of COVID-19 are improving. And that would be things like shortness of breath, fatigue, headache, those sorts of things. One of the distinctions to make here is that the loss of taste and smell can persist for weeks or months after recovery from COVID-19 and should not delay the end of isolation. These are considered markers of the disease and not necessarily resolving symptoms that put an individual at risk for being released back out into their population if they've had COVID-19. So certainly for symptomatic individuals, they can expect oftentimes that the loss of taste or smell should not stop them from going back into their population. If you tested positive for COVID-19 but had no symptoms, if you continue to have no symptoms, you can be with others after 10 days have passed since the date you had your first positive test. It's important to recognize that this 10-day period is there because it's very consistent with when we see symptoms if someone is diagnosed with COVID-19. And so we need to have 10 days not only for making certain someone's not going to develop any significant symptoms, but also at the end of that 10 days, there's a very low likelihood that an individual would be infectious to anyone else, and so then they can break their isolation. For both of these groups of individuals, it's recommended that they do not exercise during this 10-day period for a couple of different reasons. One is we don't know if the infection will become more significant during those 10 days, and certainly with symptoms. But even without symptoms, with exercise, there is a risk, theoretically, of increasing the severity of an infection if it exists and causing more issues with it. So it's recommended during that 10-day period now that there's no exercise. That was reduced from a 10 to 14-day recommendation earlier that came from the CDC. So if someone's COVID positive and they're in isolation, they should not be exercising during that time. And so that leads to who needs to quarantine. And certainly people who have been in close contact with someone who has COVID-19, and we'll discuss what close contact means here in a minute. But the CDC says that excludes people who have had COVID-19 within the past 3 months. And that means that people who have tested positive do not need to quarantine if they are identified as a high-risk contact or get tested again for up to 3 months as long as they do not develop symptoms again. And that has actually been extrapolated now to even if developing symptoms during that 3 months from their first bout of COVID-19, you should really try to identify another cause for their symptoms because it's very unlikely that it would be COVID-19. And so we know that there's very, very rare reports of people with recurrent COVID-19 infections at this point in time. There is literature and data now to suggest that this time period could be extended up to as much as 180 days, now looking at various issues of immunity around antibodies and memory T cells. And so just today, as many of you are aware, if you're from an NCAA institution, they have recommended no retesting for asymptomatic individuals up to 150 days following their positive COVID-19 test. The caveat to that being that if someone becomes symptomatic during the 90 to 150 days, they should be retested if another cause cannot be found for their symptoms, and that those individuals during days 90 to 150 should be quarantined if they are identified as a high-risk contact, given an abundance of caution with the risk that they could potentially be infected again with the virus. So after 90 days, the need to quarantine comes back for those individuals, but it may be reasonable not to test those individuals for up to 150 days and even up to 180 days at this point in time. When we think about what a close contact is, it's been identified by the CDC, as you know now, within 6 feet of someone, regardless of masking, who's had COVID-19 for a total of 15 minutes or more in a 24-hour time period. The type of contact is suggested to be discussed and really is a subjective issue, but certainly direct physical contact with a person. But that really means specific direct physical contact, such as hugging or kissing. It does not mean that necessarily the contact that occurs in sport would be considered direct physical contact with enough impetus to be able to spread the virus. And certainly there's been discussion regarding that around athletics. Certainly if someone's provided care at home to someone who's sick with COVID-19, if they've shared eating or drinking utensils, which is where we've seen a lot of spread in collegiate athletes in residential situations or in situations where they've been eating or drinking, certainly makes someone a high-risk contact. Or if someone directly sneezed, coughed, or somehow got significant respiratory droplets on you, could put you at high risk. And as you know, with contact tracing, that stay at home for 14 days after your last contact has been one of the significant issues around COVID-19. That being said, during that time of quarantine, as long as an individual is asymptomatic, they can exercise, and they can certainly exercise by themselves in a physically distanced fashion and continue to train so that they can return to sport after their quarantine ends. It is also at that point still recommended and noted that although there are some strategies that are being used by professional sport leagues to potentially quote-unquote test out of quarantine, the CDC and other organizations have recommended that high-risk contacts should not be allowed to test out of quarantine, and so that remains a debate for athletics and one that continues at this time. So how do we determine when athletics start and stop with COVID-19? We're certainly in that situation now. And how do we determine those times? How many positive tests would stop a team from participating? And how long would a team need to pause if there were positive tests? And so determining when athletics start and stop should be a data-driven decision. It should be a decision for that actual group. And so we need to get very granular and specific when we're thinking about a team or the congregate group that makes up that team and protects their tier 1 population or coaches, looking at things like either test positivity rate or, more importantly, probably their population positivity rate, which is the number of positive individuals in that total population at risk. And this is just a schematic that can be looked at if you're using these to help define the populations of when sports should start and stop. Other individuals have tried to define this by the number of individuals at certain positions within a sport, such as football, or the number of substitutes that are available. But really, by looking at positivity rates, you can be very standard about when sports can start and stop and when you can manage the infection risk. And this can really help guide you. If a team population needs to stop athletics, certainly the recommendation is that should be for a period of at least 7 days to be able to monitor and look at what happens with those positivity rates, but could be as much as 14 days if those positivity rates are significant. And in data that we have looked at specifically, it takes about 10 days for these, once you have an outbreak or a cluster of COVID-19 within a congregate group the size of an athletic team, really to move in a positive direction. So it's really probably 7 to 10 days where their activity could be disrupted before they would start back to sport. So that leads us to talking about ethics of athletics in a pandemic, which has really been one of the most consistent topics that we've talked about, and asking about athletics being essential during a time of a pandemic. And certainly we know in our collegiate athletes, athletics are essential to not only their physical wellness, but also to their mental health wellness. And the most concerning issue amongst most collegiate presidents is the mental health of students and staff. And certainly for athletes in a collegiate setting, regardless of competition level, the number one issue that has been seen is the increase in mental health issues, including depression, anxiety, adjustment disorders, stress reactions, difficulty with sleep, insomnia, and the such. We know that athletes require their sport for resources, for support, for peer groups, for helping them in their identity within their own social structure, their identity as a student, their own personal identity, and they certainly have had a lot of issues. So we can talk about whether athletics are essential as it relates to the spread of the virus, but certainly for many other health issues that have been ignored during the pandemic, oftentimes athletics seem to be an essential component for individuals age 18 to 29 to maintain their physical and mental health and well-being. One of the questions that comes up is, can we expect athletes to maintain standards that are not maintained in society? And certainly, is it fair to ask our athletes to do things more strictly, to live in a quasi-bubble, to mask more frequently, to restrict themselves from activities that others are doing at that time in order to participate in athletics? But what we find is that most athletes are willing to maintain those standards because they have a goal and the ability to compete. And certainly, as we look at most things in risk and medicine, and we think about the issues around how we look at most things, for example, in research, we try to assess risk and advantages. And certainly, when we assess the risk and benefits of maintaining these standards, the advantage certainly comes to having athletes maintain those standards in order to participate in many times. But it's really important that they understand that they may be asked to do things that our society is not doing. It leads us to ask the question about, can we make athletics safe during a pandemic? And certainly that leads to questions about whether athletics are ever really quote-unquote safe. But certainly with mitigating factors, with autonomous decision-making and informed consent, and from what we have seen this fall, with very limited, if any, report of spread during athletic events themselves, we know that if we can institute these standards, there is a path forward for athletics during this pandemic. And so it leads to the question of, should we play? And that's been a question that's been asked at various levels of competition. And certainly, I think, depending on the perspective, we found it's been about 50-50, depending on who you talk to, about whether or not we should play athletics. But we've been left with the question of, should we not play? Should we not play because the rest of society can't meet standards, or that acts in a different way if athletics are participating? Should we enforce restrictions on athletes that may not actually be helping their overall health, wellness, and benefits? And so I think we have to make decisions that are very specific to our groups about the experiences that they have and their ability to maintain their health and wellness. Certainly, it's very concerning right now with the way the infection is trending in our country for many activities. But I think there are many examples of where athletes have been exemplary in their behavior in order to participate, and have been a great example to the rest of society in maintaining their ability to continue to participate in sport. And so at this point in time, certainly there seems to be an advantage for trying to find a path forward, if we can, to allow these athletes to participate in sport when we look at the risk and benefits. And so now I'd like to turn it over to Jason Montgomery. Jason's going to spend some time here just talking about the NCAA actions that have continued with COVID-19.
Thank you, Dr. Borchers. I know we just have a little bit of time left, so I'm going to try to go rapidly, but talk about the NCAA legislative actions and the guidance that has come out. First, I think that it's important to understand that the current guidance and direction from the NCAA has come from the top of the NCAA governance structure. The NCAA Division Board of Governors is a committee of 25 individuals, 20 Division I, II, and III college and university presidents, with 5 independent members. And among those independent members is Dr. Vivek Murthy, who was the 19th U.S. Surgeon General and was recently named by President-elect Biden to his COVID-19 task force. Now, the Board of Governors does not have authority to adopt uniform legislation, but it can implement policies that affect the whole association, Division I, II, and III. And in this case, in response to the pandemic, the Board of Governors issued directives to all 3 divisions in 3 key areas, with the expectation that the individual divisions' governance structures would implement their directives. The Board of Governors' directives were formulated to answer 3 key questions. With respect to health and safety, under what parameters could the NCAA membership safely play sports? With respect to student-athlete well-being, what is the NCAA's collective obligations to protect student-athletes during a pandemic? And with respect to NCAA championships, given the health and safety challenges, should the NCAA hold fall championships? Regarding the health and safety and NCAA championships, the Board of Governors set forth specific standards. First, that all members should comply with federal, state, and local guidelines, and then that fall sports programs should adhere to the language in the resocialization guidelines or the return to play guidelines. And then finally, that if there's less than 50% of the membership who can participate in any division in a particular sport, that the NCAA should not hold that championship. So this resulted in, relatively quickly, Division II and III canceling their fall championships and Division I following shortly thereafter. As of today, winter and spring championships are still to be determined. Division I men's basketball has pushed back its start date for the contest to November 25th, and as many of you probably have seen just yesterday, the Ivy League canceled winter sports. In addition, the NCAA in all 3 divisions already took action in mid-October to extend the eligibility of student-athletes who are participating not only in fall sports, but also in winter sports. Now, going back to the second key area, student-athlete well-being, I'm going to review the legislation that was adopted on the direction of the Board of Governors. In each division, the NCAA adopted new legislation specifically related to an institution's interactions with its student-athletes during this time of returning to play. All are immediately effective. However, Division II and Division III rules are subject to ratification at the NCAA convention. The rules, it should be noted, were adopted pursuant to Article 3. This is significant because a failure to meet the requirements of Article 3, the criteria of division's membership, could result in the institution being subject to the enforcement procedures or infractions process. Now, as I say that, I should point out that these types of student-athlete health and safety provisions have not generally been enforced by the NCAA enforcement staff or through their infractions process, but it's clear that legislatively there's the authority to do so. The first piece of legislation that was adopted, which I'm going to call a notice to student-athlete, the rules are almost identical in each division, and they require that student-athletes who are participating in competition, institutions must review insurance coverage for student-athletes and provide information about that coverage to the student-athletes, inform student-athletes of the risk classification of their sport in the NCAA resocialization guidelines, and 3, provide information about how an institution is complying with those guidelines, and also the reliance on local community tracing to determine the source of COVID-19 infections. Now, that's language directly from the legislation. The first question to ask, are my student-athletes engaging in any fall or winter competition? Competitions broadly defined by the NCAA to include any scrimmage, exhibition, or even a joint practice with another team. And if the answer to that is yes, what steps is my institution taking to comply with the rule, and how is that being documented? This leads me to the next polling question. My institution requires written documentation of compliance with the 3 prongs of this rule, yes or no? Looks like half and half again, similar to the assumption of risk document that Demetrius noted. In that regard, the next piece of legislation I want to discuss relates specifically to waivers or assumptions of risk documents. And I think it's been pointed out in the Q&A that the NCA specifically prohibited waivers. I think that there can be a distinction between something that's an assumption of risk document and a quote-unquote waiver. What's clear is that institutions cannot have a broad advance release of liability form. So that can't be what's provided. But I think that in reality, by institutions complying with the previous rule related to notice to student athletes, those types of disclosures can create a de facto type of assumption of risk. Also, I would note that although waivers are prohibited, this legislation doesn't prohibit pledge documents that require student athletes to abide by certain mitigation measures. And I think that many institutions have implemented that type of document. Real quickly, the last piece of legislation prohibits student athletes from having their aid reduced or canceled if they opt out of participation. I would just note that in Division II, student athletes must have opted out by October 1st, and institutions in Division II can still require those student athletes to participate in other types of activities that aren't considered countable athletic activities, such as study hall and medical treatment. One final note, the athletics department will have access to the proposals and should be able to provide those to everyone on the call. And they're on a site called LSDBI, and your athletics administrators will be very familiar with that site. With that, I apologize, we're just slightly over. We certainly appreciate your attendance, and all of us are available now for follow-up questions, and we can answer a few questions now for those that are still able to participate.
So this is for Dr. Borchers. We've had a few individuals provide questions about testing out of quarantine once they're placed into quarantine, or I guess it would be isolation. Do you have any information on this topic, Dr. Borchers?
Yeah, so there's been a lot of discussion about testing out of quarantine. As many people know, the NFL, for example, uses a 5-day strategy with repeat testing to test out of quarantine. The discussion around testing out of quarantine is when is it safe to, with some repeat testing, to get someone out of quarantine knowing that they will not get the virus. And really the strategy is looking at some repeat testing to try to get people out of quarantine as early as 8 days, but around 10 days. There is not an accepted strategy yet for test out, and certainly the CDC has not endorsed, and many health departments have not endorsed testing out. But because we're looking at minimal risk, especially for those that remain asymptomatic in quarantine, there are people that are looking at strategies, and we're hopeful that we can get strategies to test athletes out of quarantine at around the 8 to 10 day mark.
Thank you. Thank you. And Dr. Borchers, this one's for you as well. Is COVID-19 uniquely related to the amount of asymptomatic cases? This question, the person asked this question said he feels like this has posed a unique challenge to control the virus. Do you have any thoughts about the uniqueness of the asymptomatic cases?
Well, I think that the issue is that we know many viruses cause asymptomatic or mildly symptomatic disease, where many people, if you were to ask them, would not seek medical attention. And it may not affect that individual. The problem with SARS-CoV-2 is that in certain individuals, it has a much more significant disease process. So if it was just mild disease in most people and it was very rare that hospitalizations would occur, we'd have probably a different approach towards the virus. But unfortunately, we know that our healthcare systems and resources can very quickly become overwhelmed with individuals that get sick. And so it does make it very problematic when 40% of people are asymptomatic, because the people that are not can become more significantly ill. It is a large challenge when you're trying to manage asymptomatic or mildly symptomatic individuals, because they may unwillingly without knowing, be transmitting the virus to others, and where they could be getting sick. But that makes it a significant challenge, especially within communities. Within college athletes, it makes it particularly difficult because we know most of these individuals are going to have mild disease, and so it's very difficult then to monitor this and to look at it. So it does make it challenging.
All right, thank you, Dr. Borchers. And thank you everyone for participating. We received quite a few questions today, and unfortunately we're not going to be able to answer them all during this webcast, but we will take the time and answer the responses via email. So thank you all for joining us today. We hope that the information was helpful to you and your organization. As a reminder, this program has been approved for continuing legal education hours. To report your hours, click on the CEU icon at the bottom of the screen. A certificate of attendance, including course numbers, will be emailed to you tomorrow, along with a recording of the webcast for watching and sharing. Be sure to complete our short survey. We use our feedback to plan future programs that are applicable to your business needs. This concludes our webinar. Thank you.